Hello, everyone. I'm Mark Plaster, and this is EP Talk, the place that emergency physicians, aka ER docs, come to talk about things that are important to us. Sometimes it's personal and fun, and sometimes it's professional and enlightening, and that is today. And my guest today is Dr. Matt Kaplan from Mission Viejo, California, and we're going to be talking about non-convulsive seizures. Matt, I'm going to just kind of hand that off to you. Tell me about non-convulsive seizures.
Okay. Well, thanks for having me here, Mark. It's great to talk to my peers. Just a little background is, as you know, I've been a night doc for 17 years. I'm a pit doc, and I just love taking care of patients. I don't like to talk about new things, devices, drugs, but what I found is we have a device now that's made a change in my group's practice and what we're doing. And for years, I've never understood why we don't have a point of care or a bedside EEG. Yep. Considering on every board test we take, you have the patient in status, you got to get them on an EEG, and half of us ER docs don't even know what an EEG is.
Yeah, we certainly don't know how to get one. At night, are you kidding me? How many times would I be able to call up and get an EEG at night? They would look at me like I was, where are you from? Where we don't do that.
And so we have a whole new aspect of taking care of our patients. And if we look back 15 years ago, they told us as ER doctors, you can't use ultrasound. You're not radiologists. You're not trained. Right. And that device is now a bedside device for us. And if we go back another 25 years, 26 years, succinylcholine was a dangerous medication for us ER doctors to do RSI. We were nasally training everyone, which was ridiculous. So now we have, moving forward, we now have a device, a bedside EEG, that's going to help us diagnose patients who are either having seizures or not. But the big aspect of this is what we call subclinical or non-convulsive seizures. Right. And this started to be recognized early about 2010, much more in the neurocritical care literature, that patients were having these non-convulsives or subclinical seizures. But how do we diagnose it? Yeah. We're pretty good. Clinically, we have a suspicion. We might start pre-treating patients beforehand, just on the history, maybe on the physical or anything like that. But now, why don't we have the hard data available to us? Most of us can't use an EEG, as you said. They're only run 9 through 5, Monday through Friday, and in most hospitals who might have them. And it might take up to 700 minutes to get an EEG, or even longer. Right. So now we have access to where we can actually put one on at the bedside and actually get the data that we need. And the patient populations looking at is really surprising. Most of the time we talk about seizures, we're thinking about our seizure patients. Right. And that's the first thing I know with this device, point of care EEG with Cerebell. People are going, well, seizures, I don't need it. The patient's tonic-clonic. And they're tonic-clonic, we're treating them. But what do we do when they're not tonic-clonic? So what if they're an encephalopathic patient, highly altered mental status? So we're talking about sepsis, anoxia, TBI alerts, strokes, stroke mimics, all this classification of these patients who are encephalopathic. Are we missing subclinical seizures in these? Right. And the literature has shown that about 8 to 15% of these patients with highly altered mental status can have seizures. Interestingly enough, my partner and I, Dr. Rick Kozak, we went back to look at the first 100 cases that we used Cerebell on, so we could see, what is this device? Is it really, can we validate and verify what we're using? Mm-hmm. And we found that 11% of our patients in the highly altered mental status were having non-convulsive seizures. So our data matched up with the national data. And then when we reviewed these cases, we were just taken back at what type of patients we were missing in our practice that we've probably been missing for 20, 30 years, that were having non-convulsive seizures.
Well, tell me this. For people say, well, non-convulsive seizures, what's the big deal? They're not convulsing. Is that really a big problem?
Yes, because the brain is still seizing. And as we know, seizures in the brain, time is brain. We have to treat them early. We also know that patients who are having seizures, whether they're non-convulsive or active seizures, the longer they seize, the more refractory they are to treatment. So we need to get medications on early and treat appropriately. And surprisingly, a lot of these patients that we found the non-convulsive seizures have been patients that we've had that have been intubated and on propofol drips. So there would be no way clinically that I can know that this patient's seizing without having that data at the bedside, without having the actual point of care EEG there to help me diagnose this.
Yeah. And as I understand, correct me if I'm wrong here, but the presence of non-convulsive seizures actually has a mortality risk associated with it.
Yes, a much higher mortality risk. In fact, we're finding a lot of septic patients, elderly, demented septic patients are coming in. They may have a tremor. We put the Cerebell on and point of care EEG, and we find that this is actually not a tremor. It's actually a small convulsive seizure,
Wow.
or that they're having non-convulsive seizures that we're not picking up. But when we do this, we found that their mortality, these patients that are having the non-convulsive seizures who are septic and demented, has gone up by 30, 40, 50%.
Yep.
And they do have poorer outcomes, but now we have a chance to at least identify, initiate treatment, and then have those hard discussions with the family about prognosis and what we need to do. But not having that data available before this just didn't serve our patients what we can do. So when we're using point of care EEG at the bedside, we're using it basically for three major indications: highly altered mental status patients, as I mentioned, encephalopathic, septic, TBI alert strokes, anyone who's obtunded. Our second group of patients we use it in is our ROS patients. As we know, with hypothermic protocol and ROS, 20 to 30% of patients can have seizures. Yep. And so the American Heart Association, along with the Joint Commission, has now come out and stated that they want to monitor these patients when they're undergoing ROS to, see if they're having seizures. But how do we do that without a device?
Right.
Currently, most of our practices are when we bring someone back, we get ROS, we treat them with anti-seizure medication. They generally go to cath lab and then up to the ICU, and eventually we'll have a formal EEG. What we've done at our institution is now we use Cerebell at point of care EEG to bridge the gap. So when they're in the ER, we get them back, we put Cerebell on, they'll go to cath lab, and then they'll go up to the ICU. And we're no longer starting anti-seizure medications on these patients because if they don't need them, we can be much more accurate with our treatment, and we have a way of monitoring the patients. And then lastly, we talk about our seizure patients. And this is a good population. As we mentioned, tonic-clonic seizures, I don't need a device to tell me they're seizing. But what do I do when they're prolonged postictal state? I think we're all very good as clinicians. We monitor the patient, we look for dysconjugate gaze, we're watching their respiratory status, and we're waiting for them to kind of wake back up. But now we have data that we can actually put an EEG on the patient, and we can see, is this a prolonged postictal phase, or are they still seizing? We had a 30-year-old female who came in, history of a VP shunt and history of focal seizures. She was non-compliant, treated pre-hospital, treated with us. And the doctor, good doctor said, okay, she's postictal, I'm just going to watch her. And 10 minutes later, the nurse decided to put the Cerebell on and found out the patient was still in status. And that's the opportunity we have to make a difference for our patients.
Yep.
And lastly, pseudo-seizures. We all know pseudo-seizures are a huge disposition problem from our ERs, and they're difficult patients. But now we can reliably rule a patient out who's having a pseudo-seizure by having an EEG on that patient, and we can say that they are not seizing reliably. And what we found with 3 of our pseudo-seizure patients in the past year, they all started seizing more when we put the device on them. And you can look at the EEG and the artificial intelligence and saying that there is no seizure burden, they're not having a seizure. And now you have hard documentation to back up that this is a pseudo-seizure. And this can avoid transfers in many patients or admissions, because those are the patients that oftentimes we've had to admit or transfer in the past to get the care to rule out a seizure itself. Yeah.
Okay, so you just say next.
Oh, yeah. So basically, you can go next. We talked about the non-convulsive seizures. Okay. This is what I talked about. Our awareness of seizures is rising quickly. As we see about 2020, the Neurocritical Care Society started saying we should implement EEGs within 15 to 60 minutes of suspected status. But again, how do we do that? We recognize that seizures occur in our ROS patients in 2020, and Joint Commission came out and said we need to monitor these patients. So again, how do we do that without a device? Yeah. We all like the Joint Commission for that. I'm talking about our clinical indications for the use of Cerebell or point of care EEG in the emergency department. And I put seizure assessment last. And the reason I do that is when I go over some of the cases we've had, it's these the high risk altered mental status patients that really have made a big difference with. If you go forward to the next slide, this just covers what we talked about: altered mental status, encephalopathy, stroke, brain tumor, CNS infection, sepsis, toxic metabolic derangements, or anoxic brain injury. And many of these patients are intubated and paralyzed. So we have no clinical assessment, yet they can still have subclinical seizures that will pick up on the EEG. As we mentioned, 20 to 30% of ROS patients do have seizure activity. And that's why the Joint Commission has come out and said we need to monitor these patients. At my institution, we use the Cerebell to bridge the patient from the ER to the cath lab to the ICU, and we are no longer giving anti-seizure medications as just per protocol. We're being much more specific with these patients. And then lastly is the seizure patients. As we talked about, the prolonged postictal period, greater than 10 minutes, and psychogenic seizures, we're able to effectively rule out seizures with the point of care EEG.
Yeah. Wow.
And again, go forward. This is the time is brain refractory to medication, but I'd like you to look at the device. I think looking at the device and understanding, really quick on this slide, I think it's important for smaller ERs. They did a study out of Stanford, and they showed they were able to obviate 94% of transfers by having a point of care EEG. Now that you're reliably able to rule out subclinical seizures, or you're able to rule them out, you may not have to transfer the patient. Or if you rule someone in, you can initiate treatment and you may either transfer or not. So this was a really, I think, a well-done study out of Stanford.
Yeah, and been one of the guys that is always transferring, because I've always worked in small places. It really helps to have the information to say this person is seizing. We have evidence of it, not just I think maybe,
Yeah. So again, we're going for not trying to overtreat, undertreat, or have imprecise treatment. We're trying to fix all that. So this is the device itself, and this is how simple it is. It's a headband that goes on. It takes me 2 minutes to put on. It takes the nurses 30 seconds. Honestly, they strap the headband on. You turn each of the numbers because that releases a gel. So there's some conductivity between the skull and the device. So it's able to pick up the sound waves of the brain to monitor the EEG. And in essence, it's a 10-channel EEG that you're looking at. The two things on the device, and the monitor itself is a little bit bigger than my iPhone. It's very durable. It's had some what they call crash testing in the department, and I've actually dropped it twice and it hasn't broken, so we're good. But there's two things. There's the AI, the Clarity, which is the artificial intelligent algorithm. That is going to be the game changer for us as bedside clinicians. And there's also the 10-channel EEG, where real time, the epileptologist can actually look at the EEG and tell us what's going on with the patient if we need them to do that, if the AI is not giving us the support. The way the AI works is, if you move forward, you'll see what's called the seizure burden. You just press that button and it brings you up to what we call the AI, or the seizure burden that the patient is having. So on the next slide, and one forward, what it's doing is it's looking at 10-second increments over a running 5-minute period. And during each of those 10 seconds, it's filtering out and looking if there's any actual seizure activity, epileptic activity, and through its algorithm is picking that up. And it's doing that for a course of 5 minutes. Then it takes a percentage of those 10-second blocks that it has epileptic activity to give you what's called the seizure burden. Okay. Now, if the seizure burden is under 10%, there's a 95% negative predicted value, or a 99% confidence that the patient is not having any seizure activity. And so we can feel confident we can rule out a seizure with that. We generally will monitor a patient for up to 2 hours, because the studies have shown that if you monitor a patient for 1 to 2 hours, they're 75 to 85% chance of not having any further seizures, especially for the highly altered mental status patients. Now, if the seizure burden is over 90%, then there's 100% sensitivity that the patient is in status and needs treatment. So this is where the devices come in extremely handy at the bedside, where I can actually monitor that. And what makes it even more amazing is if you flip to the next slide, This is just the algorithms, because we're going to ask, what do I do when the seizure burden is between 10 and 90%? And that is going to be based on your clinical gestalt of the patient, what you feel. And at my institution, anything over 50%, we will actually start to treat and we monitor. And I'm going to show you how we monitor as well with the artificial intelligence, the Clarity. So when you go to the next slide, it's going to show you this is a 0% seizure burden. So the line is down there under 10%. The patient's not seizing. They have a 0%. With confidence, you can say this patient's not seizing. And that's how we've either ruled out our pseudo seizures or the encephalopathic elderly, demented, that are they seizing? Are they subclinical? Are we missing something? The next slide, though, this is the seizure burden on a patient that's going above 90%. So what you'll see is you'll start to see that seizure burden climbing because it's picking up in the algorithm over the running 5 minutes that there's more activity in those 10-second blocks. Mm-hmm. And when they get to 90%, you know that you have confidence that this patient's in status, they're seizing, they need treatment. But what's really nice is because this is a running algorithm, as I treat them, you're going to see the seizure burden actually come down. And so you're going to see that your treatment is having an effect on the patient. And when you correlate it with the actual EEG, where the epileptologist can go back on the cloud and they can look at the time you treated and what was going on with the EEG, they can actually see that you were treating them and it was appropriate. At our institution, we ask, what do we do between 10 and 90%? Because you are going to have those cases. Between 10 and 50%, if we have a high clinical suspicion, we always treat. We're always going to do with our clinical suspicion first. But we're also able to monitor now, and we might see that 10, 20% may come down, it may stabilize. We may not need to do anything right away. Above 50%, we tend to treat at our institution. But again, we can monitor where I've had patients 50, 60%. I've given, let's say, a non-sedating anti-seizure medication, and I've seen it drop down to 10%. When the epileptologist goes back and looks at the recordings, they're like, yes, they were having seizure activity. They required treatment. Everything was done, and the algorithm is working. They're on their 6th generation of algorithms, and it has just improved just remarkably over all this time.
Wow. Cool.
Yeah. The next slide, just so you have it does have a monitor on it. People are worried, like, what if I leave the bedside? So when it does reach 90%, it makes an alarm so that the nurses will be notified. Most of our nurses, this is very nurse driven too. They'll put the device on, they're monitoring it, and they'll tell us when there's a trend or a change. Because as we all know, what's the most important thing is when there's changes with our patients. So now they'll notify us, hey, doc, your seizure burden's gone up from 10% to 30%. What do you want to do? And that will give us time to assess the patient.
Cool. That's great. That's fantastic. That's a game changer.
Yeah. And then the next slide, just you can kind of flip through so I can, this is what you can pull up on the cloud. So you can actually go back and look at what the patient's seizure burden was, at what time. You can know what time you gave treatment because they're recording it on the device. And you can actually see in this patient, you see the response to treatment. Yep. And then you see later on they had another seizure and required further treatment. So again, you have lifetime data that you're actually able to work with to improve the care of the patient.
That's fantastic.
Yeah. And as we all know, I think the faster we make the diagnosis, the faster the EEG, the faster we are to recovery, and the less refractory they are to the medications.
Yeah.
And then, as I mentioned, my partner and I did some research. We actually presented at SAEM this year and ASAP with abstracts because we wanted to vet what we were using. And you can see the EEGs by the numbers at our institution going from a Monday through Friday, 9 to 5, less than 100 EEGs were done. We were now doing over 455, 215 alone in the ED. And they were done in minutes instead of hours. Another game changer.
Wow.
This was our first 100 patients we looked at, which I mentioned 11% were having non-convulsive seizures that we would not have picked up. And our time to treatment was 31 minutes.
Wow. This is a breakthrough. This is absolutely a breakthrough.
Yeah. And then we went further. My partner, Dr. Kozak, and I did a deeper dive to look at our next 357 patients, which we pulled out just the 157 ER patients. And we not only found that we were accurately giving anti-seizure medications in those patients that were seizing, but we were holding and not giving anti-seizure medications in patients that did not need it. So 27% of our patients who were suspected of possibly having non-convulsive seizures were ruled out and did not need treatment. And that was significantly different as well. And then we just wanted to see, did it make a difference in our bed placement? And in our study, we couldn't find a significant number. I think our N was too low. And I think a lot of the clinical decisions were already made because the patients are altered. But I do think anecdotally, it did help us, in the broad picture of all these decisions that we are making. And then if you'd like, I can go over some cases. This is really, I think, the enlightening thing to most of us as ER physicians.
Yeah, I think we've got another 10 minutes or so, I think.
Okay, yeah, I think the cases really kind of bring some enlightening here. So this was case one was a 57-year-old male, history of diabetes type 2, hypertension on Xarelto. He presented to the ED for intermittent confusion for the past 2 days. Per his wife, he was seen in the ED 5 days earlier for similar symptoms. He had a complete stroke workup, included head CT angiogram of the head. Everything was negative. So today they did an MRI on him, and it was negative. They placed a Cerebell on the patient, and within 76 minutes, they found that the patient was having seizures, which was causing his intermittent confusion. This patient did well, his 3-month and 6 months recovery. He had no further episodes and recovered well. Again, this is not a typical seizure that we would think of, and this is a typical patient I think we see nearly every shift or every other shift. Case 2 was a next slide. I believe
it's not letting me do that for some reason.
Oh, there we go.
Okay, here we go.
This was a 78-year-old male who was on Eliquis, history of AFib, aflutter, hypertension, and he did have a stroke about 6 months prior to this episode where he did receive TPA. He was status post an ablation 5 days prior, and he was brought in by ambulance for expressive aphasia. He was brought in as a code stroke, no other focal neurological findings, went to head CT, everything was negative. That was done within about an hour and a half. We placed the Cerebell on the patient at 10:07, and by 10:10, he was receiving treatment for having an active seizure. Yeah. Now, I will say we didn't use the Clarity AI on this patient because it hadn't fully kicked in over the 5 minutes. Our neurologist happened to be at the bedside when we put it on and was reading the EEG live time. This patient
made a believer of him, didn't it?
Oh, yeah, but the AI did kick in and showed it was positive as well. Yeah. And this patient was diagnosed with expressive aphasia secondary to recurrent seizures. Since then, we've had 3 other patients with the same diagnosis. We've actually changed our stroke workup to now include placing a Cerebell on the patient if we cannot find any cause for their neurological changes or neurological condition. And that's now our standard of what we're doing at our stroke center.
That's cool. That's cool.
Yeah. Case 3, this was an unfortunate 30-year-old female, history of medulloblastoma, status post resection, in remission. She did have a VP shunt. She also had some issues, I think some non-compliance with her medications. She was brought in for a focal seizure by the EMT, treated pre-hospital, treated further in the ER. Like I mentioned, the doctor's a great doc. He was watching her postictal, disconjugate gaze. Let's just let her wake up and we'll be able to get her home. The nurse ended up putting a Cerebell on the patient after some time and found out she was still in status. Wow. This patient received further treatment. She did well, and she was actually improved and able to discharge. But again, how good are we without having the data to support it? Yeah. Case 4, this was a complicated 55-year-old male in stage renal disease, dialysis, coronary artery disease, diabetes, came in for sepsis, treated for, ended up having meningitis, negative head CT. And during the course of his stay in the hospital during the night, he started having some visual changes. He would report that I'm losing my vision, a little bit agitated at points. And it started to escalate through the night. By the morning, where he was hallucinating and unresponsive, he had to be intubated. They placed him on a Cerebell within 45 minutes and found out he was having seizures. And he recovered well. But again, this is a patient, we might have missed the seizures in this one with an aura, and maybe he was having some convulsions that weren't picked up. but he would have sat on a ventilator up in the ICU for a good 24 to 48 hours until they tried to wean him off, and they had difficulty before he would have been placed on a formal EEG. So having this early intervention probably had a big impact on his long-term care.
Wow.
And then case 5 is an unfortunate 57-year-old female, history of alcoholism, well known to our emergency department. She came in, had a hepatic encephalopathy, and was intubated for airway protection. It was not until day 2 that they placed her on the Cerebell, and we found out she was in status. And we look at this case and say, did we miss an opportunity? Could we have looked earlier? Could she have been seizing earlier? Or was this withdrawal seizures maybe 2 days out? We don't know, but it does open our eyes that we have a device now at the bedside, a point of care EEG, that we can monitor the patients. And I'm going to give you one last case that we've had recently that I don't have a slide for, that has, I think, the biggest impact. We all go down the wrong rabbit hole. We had a 26-year-old male brought in by paramedics for a drug overdose. He was treated with Narcan pre-hospital, treated with Narcan in the ER. He was intubated, had CT negative, his labs were normal. His urine drug screen was negative, and we are fortunate we're able to test for fentanyl at my institution. So everything's negative, and before the patient was going to go up to the ICU, they placed a Cerebell on him, and they found out he was in status.
Wow.
So this 26-year-old male, no structural abnormalities in the brain, no history of seizures, no history of drug use, was not around anyone with drugs. He hadn't even been around anyone, which we just went down the wrong rabbit hole. Yep. Would have probably sat up in the ICU for 24 to 48 hours before we put a conventional EEG on him. And his outcome, he would not have walked out of the hospital 2 days later. Right. So it's really, that was a game changer in itself to show what we can do with this device. And then this is just our protocol that we've developed at our institution, because we feel fairly comfortable now as with the device at above 50%. We as ER doctors, we're treating, we're monitoring, and we'll call the epileptologist during the daytime, but in the middle of the night, we're fairly comfortable, and he's comfortable with us doing this as well. Not to mention, I am fortunate that we can still call him at 3 a.m. He doesn't have an issue with that. We're lucky, but we've developed a much better workflow. One, to rule out seizures, and two, to rule them in. So, like I said, I've never wanted to get into speaking or talking about products. I like doing my shifts and going home and enjoying my life, but
this is a game changer.
This has changed how I practice, and these cases in themselves are just, amazing.
Well, thanks a lot. We're out of time, but this is one that we might want to come back to and dig into once the viewers get a chance to look at it. And this is great. This is great. I'm sorry I had so much trouble getting the slides up, and we might have to come back through this a little bit slicker operation. But Matt, thank you for joining EP Talk. This is really, I was looking forward to this, and you haven't disappointed. This is really, really a game changer. So if your hospital, if you're not aware of this, I'm speaking to the viewers, listeners. If you're not aware of all this, check out Cerebell, 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 and you'll learn something. And it's amazing. So thanks for joining us today. And Matt, thank you for joining me here at EP Talk.
Yeah, thank you for having me, Mark. It's been a pleasure.